what are we going to talk about today? We're talking about the neuropsychiatric diseases, disorders. That's a lie. That's not what this talk is really about. It's about altered mental status. And what I'm going to tell you is this. There's easy altered mental status. I give lots of talks. I'm a neuro guy on the brain. So when we deal with coma, I can take you through all the Plum and Posner things. That's not your problem, ladies and gentlemen. In America today, we are graying as a nation. You see this crap right here? The stuff that makes me less popular at bars with young women, okay, right here. This stuff. You're going to see more and more old people. I know that in a lot of your places, you now have senior ERs. Is that right? This is like kind of a marketing thing, or geriatric ERs. Hello, America. You've always had senior ERs. That's who shows up. And if you look at the numbers over the last 30 years, there's more and more of these people. And the question is, can grandma go home? Right? That's the tough question. When you're in there and blatantly psychotic, that's not a problem. We hit you with a Haldol blow dart. All of a sudden, you're much more pleasant. All right? Wild and crazy and drunk, and as Billy said, I come from one of those places which was a center of excellence for drunk and rude. And we were very good at it. The tougher questions are going to be deciding this. Is this craziness? Is this depression? Or is this organic disease? That's what we're going to do, and that's what we're going to do in this talk. I speak of dreams, Mercutio said, which are the children of an idle brain, begot of nothing but vain fantasy, as thin a substance as the air. That's what you find, is this thin substance. Now, this is sort of a religious slide, because I put this up and you said to yourself, oh, Christ, is he going to go through this again? The answer is not much. Okay? Yeah. A lot of it bores you, all this other kind of stuff, but understand this, we're talking about cortical abnormality here. That's mostly where we're talking. And obviously there are areas where we think, where we act, where we move, and remember we established yesterday that the brain may look alike, but it does very specific things. Pinpoint lesions in some places can cause major disease. I keep one of these charts in the department. Just keep it in the department. Don't memorize it, but understand this. We divide neurologic disease in, is it peripheral? Does it follow a dermatome? Does it follow a plexus? Then we bring it into the central cord kind of thing. That's how we do examinations, and that's how we decide whether we're dealing with broader neurologic disease or something focused just in the cortex. Keep one of those around. Cranial nerves. Let me just say this, cranial nerve abnormalities are not the most common thing you see, but it is the most precise localization in the brain. When we have a cranial nerve abnormality, we know within millimeters where the lesion is. You spend way too much time. How many people write down cranial nerves 2 through 12 intact? Put your hand up. Goddamn liars. You all do. And you all shouldn't be, by the way, because you don't test all parts of all nerves. You shouldn't be testing those. This is going to be in our drill down, much more complex boot camp too. But I will take you through the cranial nerves and show you what to test, what it means, how to make sure it's real, and all of it can be done before you order a test. Only low-powered docs need high-powered tests. Cerebellar examination is, again, one of those things that whenever we're looking at the cranial nerves, we also look at the cerebellum. Why? Because they're all tucked in the same neighborhood. They bought property in the same location. If it involved the cerebellum, it probably involves your cranial nerves as well. So you'd never have a cranial nerve examination without looking at the cerebellum. Why'd you do it? What were you looking for? And cerebellum, remember, we have two cerebelli. We have the big flocculonodular lobes that hang off to the side. It controls this kind of stuff. And then you have the midline cerebellum, which controls what? Gait, standing, those sorts of midline structures and functions. If you haven't tested a function to the outside and one to the inside, you really have not looked at the cerebellum. Now we're going to get to our real business today, and that's mental status. Mental status is hard. But when you cannot assess, if someone comes in, and I know you don't want to pick up this chart either. It says, Grandma's not right. Since 1968. Again, it's one of those charts. Grandma's not right. So how are you going to take Grandma and decide, is it organic? Is it slow organic? Is it acute organic? Or is it something having to do with personality? You realize there are people who don't believe in the brain-mind dichotomy. They think it's all run together. They think there's no such thing as a psychiatric disease. It's just a different chemical in a different location, and quite frankly, we're moving in that direction in our thought patterns. But these are the things, this is a sort of a standard mental examination in the department. The orientation, understand this, the first thing you lose is date and time, right? If I'm here at this conference, if I didn't have a watch that told me that, I wouldn't know what day it is today. And that happens. The next thing you lose is specific place. Where are you, Grandma? She looks around and says, well, I'm at St. Joseph Hospital. And let's say it's Mercy Hospital. But she picked up from the clues that it was what? A hospital. Here's the break point in whether you can go home. When they can't identify the fact that they're in a hospital, if they think it's a pizzeria, they don't know where this is, that's a bad sign. The last thing you ever lose is who you are, your name. It's the only question since you were a year old that people have been asking you every day, what's your name? Now, if they can't come up with the name, brain's on the way down, seriously on the way down. But there's a clue here. Let's say they're blatantly schizophrenic, and they're kind of talking away and stuff like this, and then they say, well, what's your name? They can come up with everything else but their name. They're what? Nuts. Okay? They're just crazy. You cannot have orientation in the other fields and not have your name. It never existed in the history of the world. Now, you realize that there's a lot of people who aren't right. I learned a lot of things in emergency medicine we were talking about this morning. One thing you learn, I've learned after 40 years, is that all families are dysfunctional. Can we agree on that? Yeah, okay. That includes mine, right? You all have an uncle or an aunt who you don't want to introduce to anybody. But you got to have Thanksgiving dinner with them and all that kind of crap. And you don't get a chance. Let me tell you the dilemma. And I tell this referencing my wife, who is very smart. We're on a train in London. I was a visiting prof in England. And we were in the subway in London. There are two guys sitting across from us who are talking to themselves. One guy, beautifully dressed, bowler hat, briefcase, and a little wire coming out of his head. And he's talking. He is obviously on the cell phone. Now, the guy sitting next to him is disheveled, looks like hell. He's talking, but there's no wire. And my wife says, you know, the only reason we're worried about this guy and not the other guy is he doesn't have a wire. She thought, from a mental health standpoint, we ought to just buy him a wire. And she says, you don't have to buy him a service to go with it. He's already plugged into somebody, so it'd be all right. Memory. Memory is incredibly important. Those people who have perfect memory of the past, and you'll see lots of grandmas and grandpas in there, and again, I'm a grandpa. You see them in there. And what can they do? Well, if you start talking to them about where'd you go into high school, who were your friends, I have guys who fought the Second World War who remember everything about it. But don't ask them where they were yesterday or what they had for breakfast, because that sort of memory requires stuff to come back through the corpus callosum, and various complexes actually have to plant new memory. These are the people who are dangerous, ladies and gentlemen. So when you're taking history and you want to comment on memory, understand there's recent memory, well, there's instantaneous memory. You give them 3 things to remember. I want you to remember a banana, a monkey, and a piece of paper. I always use the same 3. That's so I don't forget, which is very embarrassing at this point in time. Instantaneous recall, 30 seconds. It does not have to go and be implanted. Then you do the stuff that has to be implanted a little bit, and then you do the past memory. Those patients who do not have reasonable recall of the last 2 or 3 days may constitute a danger to self or others, right? Those are the people who will leave a cigarette burning and can't remember it. They've turned a pot on the stove and have walked away and forgotten about it. These are the people who do represent a risk to self and others. I'm not going to go through Glasgow Coma Scale. You've all seen it. This is sort of a review of mental status. This is sort of a Where's Waldo view. I mean, if you cannot open your eyes, there's no motor response, there's no verbal response, I mean, you're sort of dead. And you kind of move up from there. But pretty much anybody in emergency departments with a Glasgow Coma Scale below 14, you're working up. I don't know anybody who ever gets out of there with a Glasgow Coma Scale of 13. Never saw it happen. It's just not part of what we do. Altered mental status, when you think it's organic, think about the age of the patient. In old people, it's their medicines. In young people, it's their drugs. But it does happen. You know, if you see the usual ebb and flow of human misery that comes into our departments, think about it. And then we divide the world into 2 groups, biochemical and sort of structural. Biochemical is AEIOU, alcohol, and various other fun stuff, epilepsy, insulin, opioids, uremia. Almost all those you can test for. Trauma, temperature. Again, complete set of vital signs in mentally altered patients is absolutely essential. You see patients, particularly the elderly who have got thyroid disease or hypothyroid, their temperatures drop like crazy. And I'm from Michigan in the winter. You know, you hear all the crap on the TV here about, oh, there's cold weather coming in. Shit, they wouldn't know cold weather if it slapped them in the head, right? You know, up on Lake Michigan right now, you know, it's 2 degrees below zero, and there's a 60-mile-an-hour wind off Lake Michigan. You know, they don't know cold here. But it makes you cold. poison, psychiatric, obviously, stroke, and shock. What's the approach? The approach is very simple. It is physical examination. It is not running to a CAT scan machine, fool. Okay, focal versus non-focal. Coma. Coma is handled very straightforwardly. Your respiratory pattern, okay? Your response to arousal. Are you decorticate? Are you decerebrate? Is it one on one side and one on the other? You should be able to point within millimeters to where a structural lesion is in the brain. No problem. Bacterial meningitis, can it change mental status? Yes, but again, febrile. These people don't have weird thought content. Most people, and here's a phrase you'll remember till humans change, till they become another organism. Most people who have organic disease have a lack of output. Most people who have a psychiatric problem have just crazy output. They have crazy thought content, right? Trick 2. When they hear voices, when they see things that are abnormal, that's almost always organic. When they hear voices, it's almost always psychiatric. You'll have to help me with this one. I want to know why, if they're hearing voices, the voices never tell them to get a haircut, get a job, take their medicines, or pay their fucking taxes. Okay? I don't understand it. What we need in this country are higher quality voices. We really do. The more vociferous a patient, the more likely it's psychiatric or drug. Right? When you think about it, grandma who's got severe dementia just kind of sits there. You say, "Hi, Grandma." Then you go away and you do something for a while, you come back and she'll say, "Hi." That's organic, okay? When they want to start talking to you about the black helicopters and they're ripping the wiring out of their house because they think the government's looking at, see, here's the bitch. The government is looking in on you. But if you actually say that, okay, we cart you away. Oh no. And we send you to some place where you have to make, rope sole shoes and drawings and all that kind of crap. In any event, we don't know what to do. Bacterial meningitis still happens, but again, it has an organic look. There's a temperature thing. There's going to be no focal finding, but they have motor impersistence. Almost all people with encephalopathy have motor impersistence. That is, if you're checking for pronator drift, which is essential in the neuro exam, and if you don't know how to do it, you need to learn how to do it because it's 100% valid. As you do this and say, "Oh, keep your hands out," they go, and now you get mad at them. "No, John, I said keep your hands out. Shut your eyes." They go like this, hands go down. That's motor impersistence. Why? Because in certain organic diseases, they cannot maintain motor activity without direct visual input. The exam will tell you lots of things. We're going to move on. You can look up the etiology of meningitis here. We also have a list of the drugs that you would start. Here's what I really do. I call down and we get the latest gram that they put out, the latest ranking, as to what this week we're using in our place. Because this changes. This changes monthly. And so I check and see what's currently advised at certain ages. It's hard to go wrong with ceftriaxone. Really. Remember I said it's emergicillin? It's gorillacillin? It's hard to do that, but it's not enough in certain kids. If you're looking for Listeria monocytogenes, which is in only the first month of life, you've got to give an aminoglycoside of some kind. You can pick one, but it should be added. Then over 50 years of age, we assume that they get ceftriaxone again, but ampicillin or something like that must also be given again because of the spectrum of disease. Somebody's seized. They've got altered mental status, or they may. The time to see the patient is right away, before they're totally awake, because the last area to come back neurologically was the first area that triggered the seizure. If they come back and they still have a partial Todd's paralysis, they have a higher incidence of an actual physical lesion in the brain. Most people who seize do not have a tumor. Most of them do not have a physical structure. But if you do have a Todd's paralysis that maintains, you've increased the likelihood of having a focal trigger for this seizure. By the way, you don't rework up every seizure patient. 90% of our seizure patients who come in, they've had seizures before. They don't get repeat CTs. I just look up and see what they've had. They don't get repeat anything except their drug levels. Because if you look at it, particularly in the young, they're not taking their medications. Now, you have an obligation under the law, depending on the state you're in, to report patients with seizures. State of Michigan, there is no place to report them, but you are obligated under the law to inform them they can't drive for 6 months. Do they follow that? No. Most of them drive to their doctor the next day. I know that. But you're obligated to write it down. Know what the seizure law is in your state. State of California, you have to report them to who? The Department of Motor Vehicles. That is a reporting statute of which your department is required to do. It's like gonorrhea. You don't get a choice. You have to report it. And these are the kinds of things that you should know on a functional basis. We'll move beyond this for just a second. Is there such a thing as a pseudo-seizure? Yes. There are people who fake anything, okay? You thought it just happened with orgasms. No, it didn't. It's seizures just as important. And by the way, they will often then, following a fake seizure, have fake coma. Well, how do you deal with that? I'll tell you how to deal with it. Get everybody around the bed. And then I whack a tuning fork. So I bring it by their ear. They think the largest insect in the world is floating around. Then I take a cotton tip applicator, I go, and put that up the nose, and now they're going like this. Works every time. I used to have one guy who I would bring everybody around the bed and say, I'm now about to perform a procedure on the great nerve of coma. And oh God, the interns, the first years are going, where's the great nerve of coma? And they're looking through a book and stuff, and I start rubbing his neck, and I said, oh, there it is. I've got the nerve of coma. And now his left arm will start to elevate. And he brings his arm up, and oh, they think I'm a magic man. No, if you're in the condition where you're faking coma, you've got serious psychiatric problems, and we can bring them back. I never let the residents torture them. Shove needles up their feet. We had one guy who used to like to, when he thought they had fake seizures, squeeze the testicles. That said a lot more about the resident than it did the patient. Oh, well. There's Nurse Ratchet, of course. Functional disorders versus organic, as I pointed out to you, it's age-dependent. The organicity it depends very much on the background of the person. But in general, well-formed visual hallucinations are almost always organic. People who have voices talking to them continuously, almost always functional. Again, I'm not going to get into this debate about what is mind and what is brain, but just kind of keep these things involved. Antisocial personalities are what we specialize in the emergency department. Would we all agree with that? If there's a town, and by the way, everybody says the same thing to me, and I probably lectured in every state in the United States. They'll say, well, you don't understand the problem we have with those crazy people and all those mean drunks and all this other stuff. Shut up. There's no emergency department I've ever been to who didn't think they got more than their fair share of antisocial personalities. It's a part of what we do. We are the bottom of the societal birdcage. If your mama don't like you and the police don't want you, where can we take you? The emergency part. I always laugh at this on TV when they say, well, we're going to talk about the terrible cost of health care in America, and we're going to start with the emergency department. Shit, you couldn't function without emergency departments, America. Try shutting them down and see what happened. State of Massachusetts went to, Obamacare Light when they started their program. They predicted there'd be a 16% drop in emergency department visits because everybody now had somebody. What happened over the next 3 years? 6% increase in the number of visits. These guys, the so-called experts, they're basically full of shit. I couldn't have less respect for a group of folks. All right. What about anxiety disorders? We see them all the time. Understand this. We can always give you short-term medication. We do not solve the problem. This is a country that now believes that happiness and relief of pain and everything else comes out of a bottle. And it really comes out of changes in their life. And you and I cannot mediate that in the department. Can we give medication? Sure we can. And I've certainly given people medications for short periods of time. But I didn't delude myself into thinking I was giving them long-term therapy for any real disease. Bipolar disorders, we always see them at the ends of the extreme. You realize most bipolar people function every day. We see them when they're hyper to the point of unbelievability, and actually in a lot of businesses, they're very useful at that level. Why? Because they work all the time. They're great. And then we see them when they're low. But most bipolar people actually do function, and it is how you define it. Schizophrenics are a different deal. There's huge information now that says that schizophrenia is an inherited disease to some extent. Now, you have to have the right fertile soil for it to grow, but there is no question that it runs in families, and there is some genetic component. Those people who really have very bizarre formed delusional systems, they have poor social interactions, they don't work well. This is what constitutes your burned out, that and the burned out druggies, are that homeless population. You see, certain politicians would like you to believe that the homeless are the sort of politically elite who are sitting around in garret rooms reading Dostoevsky. Nothing could be further from the truth. These are sad folks. I remember when we had the largest psychiatric hospital in the world, about 12 miles from Ann Arbor, it was in Ypsilanti, Michigan. We had 3,000 people in that. They had their own functional community. So what did we do? A bunch of pinhead idiots decided they needed to be mainstreamed. And what they turned into was this homeless population that we now have to do other things with. So believe me, some of the stuff we did in the past was not wrong. Depression is where we want to. It was really where we want to go, because you don't really care if they're depressed. You care about what? Are they going to kill themselves? Can we stop all depressives from killing themselves? No. But one thing about we can't fix dumb, but we can occasionally help crazy. We have a very poor system now in the country of dealing with severe depression, and here's the joke. Half of your antidepressive medication, what's the side effect? Depression. And they want to kill themselves. Pretty much, if you come in and the family says, John's loading all of his guns, and here they are, and he's going to shoot himself, I'm not letting you out the door. I'm sorry. I'm not carrying that with me. I've got enough sins now that I've got to carry to my grave. I ain't carrying that one with me. I tend to be relatively aggressive when I actually see a plan, guns, knives, all those sorts of things. It does impress me. Now, are they going to be fixed forever? Nope, but it ain't going to happen on my watch. Women try to kill themselves more than men do. Men succeed more. That's just the way it is. And I think that there is a gradation in suicide attempts. You know, I've seen a 15-year-old girl who took every Bactrim in the house because her boyfriend left her, okay? She did kill somebody, billions of bacteria in her bowel, all right? But the chances she's actually going to do something are less. When I have a 45-year-old alcoholic male who's lost his job and collects 357 Magnums, there's a higher risk that those people are going to blow themselves away. We need to kind of think about it. We're going to move on for just a second here. Delirium is, by definition, an organic process. When you're delirious, it's an acute process, it's organic, it's mostly biochemical or infectious. Dementia is the tough one. We are watching as we age, and I speak, and I've been visiting Prof in 17 countries. Everybody in the Western world has got a growing problem with dementia. You're not alone. Here's your job in the emergency department. Are they dangerous to self or others? Do I need to get them placement tonight? That's the question we answer, because you ain't fixing dementia. The bottom line is, when you start to get regressive reflexes, when your output goes down, when you start to have some spasticity, you're getting dementia. And I better finish this talk quickly because I'm about to get it now. Malingering, just give you a word of advice about this. Be very slow to put this on your chart. How many people have been wrong when they thought that somebody was full of crap and they actually had a real disease? Yeah, we all have at some point in time. Not a good thing. We've got a list of some drugs here. I keep that around. Just understand each group, but you'll never keep up with all the drugs that are happening. So, ladies and gentlemen, it is a pleasure. I'm glad I get to see you first in the morning where you're still awake. And remember that we're more here. We're more than just a group of doctors and nurses and PAs who've come together. We are that small few, that band of brothers who actually take care of the people of the United States. Thank you.